6 months later, basically, CHW really helped Mr. Jones with his financial situation, his housing issues, and then the CHW continues to help him. And I'm going to give you my chair if you want to. And then, moving on, this is now your part.
So
Now
do
you
you
take
guys
it.
have copies of this?
No, they don't have that.
Okay.
So
Sorry,
we
of what?
have to.
Huh? Of these?
I thought you only wanted one printed. Sorry.
Oh, no, I wanted
presenter.
multiple.
Okay.
That's okay. It's
Sorry.
on the,
Yeah, no, it's
Don't
keeping
worry
them in
about it.
suspense.
Yeah.
It's actually
It's
keeping them in
okay.
suspense so they can
Yeah. It
can
worked
think
out
over.
perfectly,
Yeah, no, it's
actually.
worked out well to have it like that actually.
Nice.
Okay, so
you
yeah, you
think
guys
you
want to read?
wanna-
Yeah, no, you guys can read it. I'll sit for.
Okay. So,
a minute, just 'cause
hi,
I'm
I'm Pete Miller. I'm a general internist. I work with Deidre and everyone on projects, and I'm also a hypertension specialist in general internal medicine person. So I hope that we'll never have to talk to any of you because the community health workers and the care managers will take care of all the problems. And so, but we are there at the final step as a resource for the care managers and community workers if somebody's not controlled at the end. So I'm also a clinical trialist, so the purpose of this study is to get people who are not controlled in terms of blood pressure. As you're well aware, there are a lot of issues related to adherence and blood pressure control. And so I think where we would be engaged is at 6 months, if you find that the people enrolled, the participants enrolled are not controlled, and you've tried your best with all the resources that you have to engage the patient and the provider, and still they're not controlled. And so this is common. But we hope with the 63 people at each center that there'll be very few that you need to discuss with us. But we want to be an open resource for you. So we have a way, if you find participants who are not controlled, for you to contact us. And I don't know if you've gone through that, Jim.
no, and so actually, what I was
Yeah, we
hoping,
had-
like, oh, you did?
We had a whole thing on it, yeah, with the
Oh,
with the
I didn't
with the
realize
care
that.
managers on.
Okay.
Was that yesterday? My days are
2 days ago.
2 days ago. My days are all
Yeah.
mixed up now. Yeah, 2 days ago we went through the whole process. This what we were trying to do today is keep going through with Mr. Jones,
Yeah,
who
keep going
who's the
with him,
case.
okay.
So the care managers have gone over the process. We're just trying to give them a sense
Yeah.
of.
So
you
the
know,
process
a
would
time.
be, you would contact us. We plan to meet. Deidre's on the group, and we have a cardiologist and a general internist who focuses on psychiatric disorders, and we have an endocrinologist. So we have a team that we plan to get together weekly, and we discuss cases that are sent us. So some of the sensitivities, as you know, are providers who are taking care of patients and people are not controlled. Sometimes there's a sort of proprietary ownership of the patient, and I really don't want somebody else, mucking around with my patient and giving me advice when I don't know who you are. So we're trying to set it up that we want to be a resource where we can offer advice and hopefully we'll help you communicate with your provider. This is some recommendations that another group has recommended, and so we hope to help you in some way, but we don't want to in any way sort of usurp a care, or because we're not really taking care of the patient ourselves. You are, and your provider, and you're at the front lines, and we're sort of at the back of the room and making advice based on what we see. And so what I would see at this point as part of the specialist care would be you would reach a point where Mr. Jones is still not controlled. And so it's been 6 months, you've tried the care management approach, you've tried all you can, and now he's coming back. 6 months later, his blood pressure still not controlled, 154 over 102. The metformin, he was on 500 twice a day. He's not taking that now. He's going every other day, I guess 500 milligrams twice a day, every other day. His A1C has come down to 8%. Ideally, he probably went under 7%. And he's noticing an accelerated chest pain. So this is what I would see, we would see as a group at this point. We don't know much about Mr. Jones coming in, but this is what we'd get information from the contact sheet that you get. And so And I know you've worked on lifestyle and adherence and reducing barriers to purchasing medications, but these are the types of issues that come out, and they're difficult. So
Can we, can I just add one thing? So we, just to have them maybe, for one, care manager who's here, to think about, so if that happened, think about in your practice, if you know, just with this case, like what would be, think through the next steps, you know, based on, because we talked about what the process would be, right? So maybe pause here and think about if this is a scenario with this Mr. Jones, what would happen in your practice?
yes, so we would, yeah, I'll in terms of discussion, we want to have a discussion, but it sounds like you've gone through a lot of steps, right?
But they haven't done a case. That's what we're trying to help them do
With this-
do like a thinking through what they,
Yeah.
how they would operationalize it with this guy.
Right, so,
Danielle, I don't know if,
Yeah,
what do you think?
I'm thinking, so he's back in 6 months. It looks like, you know, he essentially stopped taking the blood pressure medication because he is having some sexual dysfunction, and that's not cool for him because he want to still be able to do his thing. So I would talk to the doctor first before even stepping him up, because maybe, just maybe, if we find an alternative blood pressure medication that wouldn't affect his libido, then that would essentially, and then I could do some motivational interviewing around the fact, well, what if we can offer you a blood pressure medication that doesn't affect your being able to have an erection? And he might be like, okay, I'm down for that, you know, and so then you say, okay, well, let me reach out to the provider and find out what we can do. And then at that point, this whole like a reassessment thing would sort of start over for me, because then I would get him the new blood pressure medication, and then if he's doing the home monitoring blood pressure for me, then I would sort of get him to start back up doing that, and then when I call him on a bi-weekly basis, sort of have him to go over what the numbers are. And I'll stop right there because that's where we are with him.
that's good. So looking back at the case, he originally was on ARB, Losartan, and then not controlled, and so he was, a beta blocker was added at the 3-month visit. So now he's having sexual dysfunction. So that's a good approach, you know, and in a sense, yes, beta blockers are associated with that. And so that's sort of a low-lying fruit, you know, maybe you could recommend to the provider. So a couple of issues.
But I could see, I'm sorry to cut you off.
Yeah.
I could see how this could be a step up to a specialist just to get sort of what they would think about the fact that he's on the beta blocker for a reason. So
Yes.
what would be an appropriate replacement, given that he really needs a medication that can sort of do what the beta blocker is meant to do.
Yeah, that's a really good point because of this issue right here. He's having worsening chest pain. So he probably was put on the beta blocker because he has coronary disease. I didn't see it too well characterized, but he's got underlying heart disease. And so the beta blocker is an appropriate medication for him. And so he's got an ARB now, which is great. Now the beta blocker causing sexual dysfunction probably added because of the secondary benefit in terms of prevention of cardiovascular control of heart rate. So yeah, it becomes complicated. And I agree with going back to the provider. He disclosed that he's having sexual dysfunction with this medication, but it's maybe a necessary medication. So is there an alternative to that? That's a great point. So,
What
Can I ask a question?
Yeah, please.
Not mean to interrupt any of you. So we have a number of community health workers in the room too. Actually, unfortunately, you're outnumbered. Dorothea and Danielle. It's not unfortunate, but you know what I mean. But I think what's also interesting is, do you notice something about the CHW in this scenario?
He disclosed that only to the CHW, so I would
So,
hope,
so let me ask
that
the
there would be a
CHW
communication.
something. So
Yeah.
for you guys who are community health workers, what would you do in this situation? How would you get involved?
I would document and send it out there, especially if it's regarding medications since I'm not clinical. I don't really like to touch that or, give them any advice for that. But definitely right after it's listed, I would, let her know. Then after she comes up with a plan, I'm sure she'll relay it to me. And then if she needs help, telling the patient, then that's when I'll get involved again.
What do you think, Lauren?
I would do some motivational interviewing with him, since he seems to be open to the CHW, and report it back to the
I agree
to see
with,
what's going on.
yeah.
Because that's a good point, because you can ask him, okay, did your sexual functioning decrease when you started taking the new blood pressure medicine? And when you stopped taking the blood pressure medicine, did you notice that you was having chest pain more after you took it, or was you having chest pain, excessive chest pain while you were taking it? So motivational interviewing, that would be good. Those some questions that you could ask.
And what did you think, Mary?
Well, again, the motivational interviewing and definitely the open communication with the case manager. And I would actually say to the patient, well, thank you so much for letting me know about what's going on with you and the metoprolol. That's a valid concern that you have. And then kind of go with Dorethia in regards to, are you monitoring your blood pressure? What do we do? And how are you monitoring your blood pressure? Are you doing it at the local Giant, the CVS? Because sometimes those, not that I would say this to the member, but I would just be a little concerned because sometimes those readings might not be as accurate. And then too, I just think that open communication with the case manager is going to be extremely important because you're dealing with the medication and symptoms and things along that line. I would, and especially with the nitro, because that's a medicine that always puts up a red flag for me when nitro is involved.
Could I follow up with that? Because that was very concerning to me as well. So if you pick up as a care manager or community health worker, somebody saying, I'm having accelerated chest pain, it's getting more and more common with less and less activity, that's really a referral for further evaluation. In the case that you saw, it wasn't too well described, it just said he had coronary disease that was diagnosed. But it seems to be getting accelerated. And so it would be an opportunity to say, you really should go talk to your cardiologist. And even, potentially.
And if it were face-to-face or even on telephone, I would probably even suggest to the patient or ask permission, well, is it all right, can we get Danielle on the phone? Can we do a three-way conversation in regards to this?
Yeah, because now that you said that and mentioned that it does stand out as the priority intervention, because it's a change of status, because he mentioned that, okay, I'm having chest pain, it's worse when he's working or with his girlfriend, so he's just always having it, it's worse, and then he has to sort of increase how often he's using his nitroglycerin, so that could be a change in his cardiovascular status that we would want sort of emergently to be evaluated, so I see that.
If I could summarize, there's a few things I just wanted to close the loop on the CHW part. So I appreciate what you all said because it really dovetails with the way that the community health worker is supposed to work with the care manager. So we know a lot of times people do only say things to CHWs that they don't say to a primary care provider or even to a care manager that they like. And I was really struck and impressed by the fact that you all said motivational interviewing, we need to make sure we engage the care manager, and we need to really ensure that we are maintaining open lines of communication, because if they're just telling you it feels, sure, that feels good to have a secret, but that doesn't improve the patient's well-being, you know? So I thought that was really great, and it also makes me aware that you have a very strong sense of how to coach, how to implement coaching techniques in the context of patient communication, that you know how to talk to them in a respectful way and still maintain his confidentiality and respect, but get him the help that he needs.
I think that's great. I wanted to, just to bring up an issue that came up when we talked the other day about the step-up process to the specialist corps. So Danielle, maybe you could speak to this a little bit about how you would communicate about this patient to the PCP, to the provider that is following him.
Absolutely. So I would, now that we pointed out this change of health status, I would definitely talk about that first, because to me that's like a priority to see like how we should act. Should we get the patient to come in? Should we send the patient to the emergency room for evaluation, just to clear him of like a heart attack or any worsening cardiac conditions? And then once that becomes clear and gets straightened out, then secondarily I would then talk to the primary care provider about what the patient disclosed to the community health worker about the sexual health dysfunction, which could possibly be attributed to the blood pressure medication. I would then also ask, with regards to stepping up to the specialist, find out and incorporate with the primary care provider, how do you feel if I sort of use a resource with one of our specialists and see if they have any additional expert information that would guide us in choosing a alternative medication that would sort of do what the beta blocker was supposed to do, but then also help him with the sexual dysfunction. Does that make sense?
Yes.
Yeah,
Okay.
that's perfect. Makes perfect sense.
Then maybe at that point, the provider would say, well, why don't you go to our specialist here? And so you would fill out a form. If you wanted our opinion, this group is going to meet weekly and discuss cases, so we'd be happy to discuss that and give an opinion.
Yeah.
I mean, you'll be talking with the primary person.
And I can see this happening because when you work in community healthcare, our providers are generalists, so they're not specialists. So anything that the patient has, like a cardiology, whatever, they send them to the cardiologist, and then the cardiologist makes the recommendations, and then the PCP will then sort of manage and maintain. With regards to the specialist step up,
I think that'd be
is
okay.
a great resource.
Yeah, one of the things we talked about is that we may be able to at least offer suggestions, and again,
Yeah.
we're just, it's sort of, I told them to, as they're communicating back with their PCPs, this is what we talked about 2 days ago, to kind of think of us as like a curbside, like what you could, when you're communicating with them about the value that we can bring to the care of these patients, think of us as a curbside group, a group that can provide a curbside consultation, right? So that it would be, that we may be able to get that back to you faster than the appointment that you're gonna be planning to schedule them for in many cases to physically see someone. So I don't know if you wanted to build on that, but yeah.
That's good. So maybe a couple, so I agree, and to summarize some concerning changes in his health status with crescendo angina, so it's increasing in frequency, which the beta blocker may have been put on because of his underlying cardiovascular disease, so it would be, in that case, a good choice as a second-line drug, because he was just on the ARB at the start, and then the beta blocker was added. But, you know, for him, what's more important is sexual dysfunction. So, you know, the patient-centeredness of this is that we really have to pay attention to what the patient's saying. And so, hopefully, the specialists will be able to come up with an alternative recommendation for treatment, because ultimately what's not good is this, it's 154 over 102, his blood pressure is elevated. So just some other the other things that are not controlled are his diabetes. He was given metformin, which is a great first-line drug. Everybody, starts with type 2 diabetes, usually starts with that. So have you heard in the past about diabetes and GI symptoms?
Yeah, I Miss D that Dorothea, because we were talking about the fact that his amylase and lipase and all of that was elevated. And I heard somewhere in my readings or something that, or it just makes sense for if you have uncontrolled diabetes that you would have some elevated pancreatic enzymes because it's sort of like the same system. Is that true?
I saw that as well. I'm pretending like I'm coming in at the 6-month time.
Yeah.
And I'm much more concerned with the lipase, amylase, and the transaminases all up. You know,
Yeah.
number one, is there an infectious etiology like hepatitis C? Or is this alcohol 2 beers a week really, you know, a quart a day or something like that, you know? And so, and alcohol, as you know, is one of the major contributors to secondary cause of hypertension. Alcohol and excess alcohol use. So it's a really low-lying fruit in terms of poor blood pressure control. And so I would try to look at that because that's not normal. And I mean, it could be something like fatty liver. I don't think with diabetes, when your pancreas is burning out because of type 2 diabetes, it's going to necessarily bump
Go up. Yeah, we can just
lipase.
show it, and again, that's something we just very quickly said, that ain't normal, right? When we were going through these.
Yeah, so I think it's the next one down. So this is another thing, is creatinine's 1.28, so GFRs. So yeah, so this AST elevated, ALT elevated, amylase, lipase elevated. And does it smell of alcohol to me, or so something you want to explore? And he said he only drinks 2 beers on the weekend or something like that.
2 beers a night, couple beers.
Drinks a beer or 2 after work days.
Yeah.
Beer or 2. So you
So that makes
multiply
you
by
drink
4.
Yeah, yeah.
Sorry, those values to me are still a little. Doesn't really doesn't mean a lot to me. Like how high is high for like, or what is like a normal value for those two?
Yeah,
I'm-
it depends on the
I'm just
one,
curious
but,
how bad it looks.
Like AST has, ALT has a maximum around 40.
Okay.
So these are about, this 120 is, you know, 2 or 3 times normal. So, but it's not 600. It's not like floored alcohol use, but it's a real hint to there. I mean, the other thing that can cause that, you don't want to, is something like fatty liver. So you don't want to say you're drinking too much when actually it's caused by infection or fatty livers.
I was just gonna say it's another good reason a community health worker could go out.
Yeah.
If you go in their house and there's alcohol bottles in every room, you
Yeah.
can definitely report that back,
Yeah.
and maybe the story will change a little bit.
Maybe you could explore that more with them, yeah.
I was actually thinking that along the same lines, like how does a community health worker fit into this sort of thing? Because I had forgotten that he was drinking a lot. Well, he was drinking a lot. And and it made me think, well, you know, what kind of motivational interviewing skills would a community health worker have to employ to try to help him think about his alcohol use? And what if he doesn't see it as a problem? Like maybe
Yeah.
he's not worried about that, he's worried
Right.
about other stuff.
So one thing you brought up, Chinema, is what is a problem? So what he self-reports is 1 drink a night, which is, in terms of cardiovascular disease risk, that's beneficial. So, you know, some people view, and you know, people have different views of alcohol. You know, half the population don't drink any alcohol, and they think it's bad, and you know, for you. Whereas the other half think, and in terms of the epidemiology of alcohol, a drink per day actually is beneficial in terms of blood pressure and cardiovascular disease. So the fact that he has a drink a day, you guys are talking about stress reduction. Some people have come home and that's their stress reduction, right? They have a drink at night. So we have to watch our relative, you know, putting values on alcohol is too much. 1 drink per day, if he's truthful, that's nothing, you know. And so, but if that really means he's drinking, you know, 6 drinks a day, that 1 is really 6, then that's where the community health worker could explore the household and things to try to get at what the truth is, because people will, as you know, will underreport, and nobody would say, yeah, I drink a 6-pack a day, you know, or I drink a quart every other day or something, you know. So getting at that, because that is a major contributor to hypertension. It's one of the major secondary causes of hypertension that's fixable with alcohol reduction. But if you were just to, on the surface, say that that's the truth, 1 drink a day, that's okay. You know, And we wouldn't say, well, you got to drink to cut your alcohol because you're drinking one a day, because that in no way will lower their blood pressure. So the other thing I noticed here, I wanted to go over in terms of CV risk factors. So I wanted to review the cholesterol numbers here. So he's on Crestor, right? So a lipid-lowering drug. So the total cholesterol on drug is 250, right?
Yes.
Okay, the HDL, that's total. HDL is 55, right?
Yes.
And triglycerides is 200. Right? So that higher level on a drug, 250. So yeah, in terms of general rules of thumb, if you were to see this cholesterol 200, 250.
Only one person in the room would be expected to know for
Yeah.
sure, so.
Yeah, so I mean, typically, under 200 is thought to be okay. You want a high HDL, that's the good one, which is okay. And then triglycerides are high, 200. So this often goes along with diabetes. And there's an equation to calculate LDL. So what you treat typically is the LDL cholesterol. He's on Crestor 20. So, but this is way not controlled. 150 is, and somebody with angina, established cardiovascular disease. So this might be another reason for referral, that their cardiovascular disease risk is not controlled. So, I mean, that does require, I mean, I barely understand it now. The cardiologists put these layers of when you treat, what you treat with, and what the treatment goals are for LDL. So it's very complicated, especially with the ATP3/4 guidelines, which just came out. It used to be quite easy. You would, and somebody with established heart disease, get the LDL to 75. So this person's on a statin, Crestor, but is nowhere near goal. And so in terms of, there's hypertension, there's diabetes, this is a low-lying fruit for better control of their cardiovascular disease risk factors. So,
Can I want to add two comments. One was about when we were talking about the alcohol use, that if it did turn out that he was drinking much more than that, that's also, that can also contribute to sexual dysfunction, by the way. That's another thing that, as we're thinking about what that's his priority, but it could be that sometimes patients are thinking that it's one thing that's the cause, and it's something that's been around for a long time, like the alcohol use, potentially. But the other thing, I would just wanted to make a plug for the specialist corps when you were laying out the complexity of the of his laboratory profile, right? When we were meeting a couple days ago, Danielle, about the step up to the specialist corps, we talked about how one of the benefits is that you really do get our whole group at the same time, in that for many patients, they have multiple problems, and in order to make a change to try to impact, like for example, his cholesterol, that could have implications for the treatment of, or it could have implications for, the fact that even though his kidney function is normal, it looks like it's kind of right on the edge of normal, potentially. And so thinking about, okay, which drugs are going to be better for somebody who doesn't have a completely preserved kidney function, which drugs are better for someone with diabetes, that type of thing. And having a group to look at that is going to probably give you, at least in that quick, like, curbside sense, more benefit than sending them to that isolated single specialist who is doesn't necessarily have expertise in those other considerations.
Yeah.
I guess another comment back to the metformin. So, A1C is elevated, diabetes not well controlled. Put on metformin 500 twice a day. That's a decent dose. Usually try to go to 2 grams a day.
Yeah.
And so
a gram BID, right?
Yeah, gram BID is to try to get it up to there. But he's reporting GI side effects, which are common with metformin. And he said he's doing it every other day now, which is okay. But when you put together, it does look there are a lot of adherence issues with him, which is why community health workers and case managers are so important. Because it's all, in my mind, about blood pressure. It's all about the drug. It's about taking the medications. Really are what helps lower your blood pressure. I
When
mean,
you
the
take them, they
lifestyle
work.
things, I do the DASH diet, we do all studies on that kind of thing. It's, you know, it's fairly effective in adherent people, but some people are not very adherent, and I would say he's probably one of those, and if we have a suspicion of sort of excess alcohol use and sort of not, you know, not tightly controlled in his medications, then it makes it a real difficult time to get him controlled, you know, with, and that's why, you know, I wish you luck with that, because you're getting the more difficult participants, and we all have them in our panel who come in not controlled, and you're just trying to scratch your head, why not? And, so the metformin, you know, potentially what you could do with that, since it's 500 twice a day, say, okay, we'll go to 500 once a day. And then we'll try to build up later. You build trust. I hear what you're saying. Yeah, that's a side effect of the medication. Well, we'll just cut the dose on that, and then we'll try to build back up. So let's see what else. Comment I had was, you know, for the blood pressure medication, assuming that he is compliant, that there's nothing else major going on. I guess Deidre's leaving, so you want to say goodbye to everybody?
Oh, no, bye, everybody. I was going to be quiet. I'm leaving you to die.
So any specialist care, Deidre will be at the front
Oh, yeah.
lines of answering the questions, and we'll get you back a response within a
I'm sorry.
a week or
Bye.
two. So, yeah, in terms of, there are other medications, something like a, you know, a diuretic could be used. So there are a lot of mixtures of medications that we could try. So how is it interacting with primary care providers when you give recommendations, or when you say, you know, this
Depends
person.
on the provider.
Sure do.
It depends. But me, I am assertive anyways, because I sort of broke out of that being shy and sort of getting a hard no from a provider from working on the units and having to advocate for patients, because the doctors are not staffed on your unit. They only come around when they do rounds or when some drama is happening, somebody's crashing or whatever. So in the interim, you have to be able to sort of anticipate your patient's needs and know what's going on with your patient, and be able to communicate the needs and the importance, and having all your information together to give to the provider. Because if you don't have all the information, it's just kind of like wasting their time or whatever.
Yeah.
So you want to make sure you have all of your facts, all your info, everything that you need, patient symptoms, and then give that to the provider. And usually they'll listen, they'll take recommendation.
I like that a lot. Yeah, get data. People like
Yeah.
data, and the providers will really listen well if you have their numbers, their blood pressure's not controlled, their lipids aren't controlled.
Can I ask the same question for the
Yeah.
community health workers? How is it for you all when you interact with providers and try to share information with them about the patient?
I don't know about them, but I never interact with my provider.
I usually have them come to me,
Mm-hmm.
usually. I mean, I've sent a couple of like staff messages, but it all depends on who you're talking to.
Yeah.
It really does.
Part of why I ask is because this is supposed to be a collaborative care team, and we want the community health workers to be embedded in that team. So really interacting in a meaningful way with the providers, not just with the care manager. So I was just curious to the question.
Yeah.
Well,
So-
I actually have I have a good rapport with the providers that I work with at the site that I'm at. We correspond really well together, and I'm actually comfortable with walking around into the office and talking about patients that that I may have some concerns with, or some things about the patient, and I've had talked about over the phone, and I go to express to the provider, but they're really good with providers. They're really, really good. And on top of it, when I express something, they go right in, because even if the patient ran on medication, I need refills, and I put that in patient card medication request, and I'll go around and say, oh, sure, no problem. I didn't do it, like, Lord, put it right now. So I like that.
You work with a good team.
at Saratoga.
Yes, I do.
We gonna have to travel soon to all the other centers.
And encounter my special.
And then it's sort of like knowing the provider too, or like sort of like hearing through the grapevine, like what this provider likes, how to best approach the provider, because some providers sort of don't want you to like go messing with like chill. Anyway, like for instance, I thought I was helping one time by doing a patient's medication reconciliation, which is a part of my job functions, and I'm clearly capable of doing it. And one of the providers that I was working with, and she's a nurse practitioner, she like zapped out because I like help the patient with the medication reconciliation, and that's what she does for the patient at each and every visit, and she doesn't need me to do it. And I'm like, oh, okay, cool. And I never did it again for her. You see what I mean? So it's, sometimes you have to go through it, maybe once or twice with a provider, but hopefully you will never have to. But sometimes learning the provider's like attitudes, how they practice, what they want you to do, what they don't want you to do. But for the purposes of this study, you know, I'm gonna pull out all of my like autonomy, like nursing hat, because this is a study that we're doing. It's not just like your patient or whatever. It is your patient, but this patient is involved in the study, and this is sort of what we're implementing with this patient, like whether you want my input or not, like it's gonna happen, you know. And I feel that once, oh, and then trust. Your provider has to trust you too, has to trust that you're like competent, and that you're gonna do what you're supposed to do, and essentially do what they recommended as well for patients.
What about, Mary, what do you think? Because I know, all three of you on the JHHC side, you're not just based in one clinic, so you're kind of, you're based regionally, right?
Right, and to be honest with you, I really don't have any interaction with the JHCP clinic in my area. I was getting ready to say that the one practice that we service, that Hopkins provides the service for, that I help with, the three locations, there's one location that the PCP, they want that interaction with the CHW, not just the CM, they enjoy that interaction. There's another group that they just want to work through the CM, but the patients will let the doctors know what's going on, and sometimes you'll get oh, kudos, I heard from Mrs. Smith that, you know, you got her transportation, thank you so much for helping out. But that might be the only interaction.
Both sites, nor do we have space at that site. So I think not sometimes having your face in there, because I at one point was going to all of the meetings, and it's still like, oh, no shade. So, and then I'll send like a message, and one of the providers, I was helping with the NC mobility form, and I needed, you know, the PCP to fill it out, and I was sending her messages, and you know, it's bad. So it's a little barrier, I guess.
So would you go through the care manager if you're having difficulty accessing the provider? How do you step it up?
I go there.
Yeah, okay.
And I
good.
just,
Yeah.
usually they'll be in a meeting, I'll drop it in their mailbox. It's just, especially at one of my sites, it's a lot of, I guess, a lot of hierarchy, because then it's drop it in the mailbox, and then it's like, oh, that one looks good, and you need to scan it with the front desk first, and the front desk is like, who are you? There's a fee to this, and I'm like, it's
It's like
They're big.
barriers
yeah, it's,
within your own practice that you have to overcome.
And I know when all of us started, our program was pretty new, so I think the officers are still trying to get used to us and, you know, what we do, so I think that's part of it too.
Yeah, that makes sense. And I think that's where the practice champion at this site is going to play an instrumental role, because that way they'll help introduce you, they'll reinforce who you are, and then they'll also state who you are in the context of the Rich Life Project too. And the thing that came to mind as the three of you were talking, and even as you were talking to Vanessa, is the fact that if you could use the EMR as a way to help with the communication as well. But, yeah, those were some thoughts that.
I do like Vanessa's your name. Yeah, I do like sort of the personal interaction as a provider myself. I actually, as opposed to her example, I like interactions where somebody else is watching out for this patient beside me, and I'm thankful for that. You know, so you get updates and you get communication, because oftentimes you'll see people just every 3 months or every 4 months, and each time you're trying to remember, okay, what are we working with this person, and so I appreciate interactions with MAs just to remind me about people who we need to spend more time with and pay more attention to. So, yeah, I think as far as how this process works in terms of, I'd be interested to hear how you're going to handle. So we're doing more recruiting. This is a randomized trial, and I'm a trialist, so you get one arm gets one thing, one arm gets the other, and then in the end we compare control rates at the end. In my mind, I love to see a control that gets nothing, because we want to see what the usual practice is like. And then when in the other arm of the randomized trial, just to show you, a randomized trial is where there's a problem, and we've identified the problem, which is people who are not blood pressure controlled. And then, so we have some kind of screening process, and then we randomize 2 groups. And one is what we call a usual care or control group, and then we're calling in this case an enhanced care. So everybody gets some level of attention to this BP not controlled, right? And then the usual care, and then this is the more intensive arm. So your centers will be randomized to one of these groups. And then for us to be successful at the end, I think our intention is to show that one arm is stronger than the other. And so, of course, we don't want the usual care to be the strongest, because then that would say, well...
So that would be the standard care.
Yeah. Yeah,
And
that's the
intensive
standard
care
care
would
is
be
the
the
usual...
collaborative arm.
Yeah. So we're hopeful that this comes out. So everybody will be out of control at baseline, those 63 people at each center. And but then you're going to have a lot of other people at your center that are not in our study. And so how are you going to handle that? How are you going to differentiate who is ours? You mentioned, they're in our study, we'll pay attention to them. But you're going to have a lot of people who are not in our study. So are you going to say, well, these are the chosen 63, and I'm going to spend more time with them, or how are you going to handle that?
Well, no, they are going to let us know who the patients are, because what do they call it,
RPAs.
the RPAs will be conducting a little interview when the patients state that they're willing to participate, and then they will set up an appointment with the CM for that first initial visit.
Yeah, okay.
So that's how we would know.
Yep.
And the second piece of that is, at Total, I'm going to be dedicated to the patients in the study, because I'm going to be the only care manager with the whole 100 and some odd patients. So the 63 patients at the 3 sites that we have.
Okay.
So that'll be my caseload.
Okay. So you have 3 centers, 63 at each center.
Yes, and then our community health workers, they're the same as well. They're dedicated.
Mhm.
But the folks at Hopkins, I feel bad for them, because they're not. Like, they still have their regular caseload, plus have to deal with the patients
Right.
that's in this study. So I think for them, it's going to be
That's a difference.
tough trying to juggle
Yeah.
the demands of it.
Can I just ask a point of clarification? This is just logistical. I thought that there were going to be 2 care managers at Total Health Care, so it's only going to be 1?
It's my understanding that it is supposed to be 2.
Okay.
You said it's in each other?
I don't know.
Okay, I was just
Unless she
wondering.
We already had Danielle. Danielle is wonderful. I had worked with her at Kirk because she worked with infectious disease. She did an awesome job.
Oh,
But,
you're the one. Donata, that's you.
Yeah.
Okay.
And I managed already like over 100 patients on my own at Total, just sort of seeing folks and these are unduplicated visits. So you just kind of do it as time progresses, because you won't see the same patient every month, but you'll see maybe like 4 or 5 patients a week, and then those 5 patients might get your assessment. You might be able to get the assessment done, but it was tough in my old department in the infectious disease department, because we sort of had to keep up our like productivity. So I had to schedule patients on my schedule to see them, do a case management medical case management intake on them, have a plan of action, and get all of that rolling, so that at the next follow-up visits, the only thing I'm working with the patient is this sort of plan of action items.
I think what will happen over time with these 63, at least focused on our study,
They'll
but
fall.
others you can imagine, is that they'll, sort of fall out of attention because they're controlled. And so you have them on a regime that's good and they're compliant, and you can back off. I guess that's the approach, right? They're okay, they're controlled, they're adherent, they're with the program. So, what we hope over time is that there'll be less attention paid. So everybody's out of control at baseline to be eligible and randomized. Over time, we're hopeful that people will become controlled, and that for us, the outcome for the study is what percentage of people, so at this point, 100% are not controlled. And in the usual care arm, like, what do you think at the end we're hoping for in a couple of years? What percent will be controlled? So, control is 140, 90, over 90, greater than.
Maybe 80% of the folks in the study.
So in the intensive arm, 80% should be controlled?
Yes.
Yeah. And what are we hoping for with the usual care? Like, if you're just doing your normal thing, without the additional layers of specialist care, things like that.
Yeah. That would,
It would be less, right?
okay.
40, 50?
Yeah, so 50. I like that. I mean, as a trialist, this is what you want to see. I mean, as an internist, you want to see this, but as a trialist, you want to see a delta here. You want to see some kind of difference, so we can say that that's a better approach than the usual care approach. So, and we're hoping that all the sort of the added value of the in the enhanced care group, but we also hope that people will become controlled over time just with getting the enhanced blood pressure monitoring and layers of care. So that's just to give an idea of what the study design is like, and then we do this assessment at the end and the success of the program, so that it
I
can be
see.
funded.
So you guys on the back end have already, are planning to do a comparative group of patients also, so folks who are in the intervention group and then folks who are in the usual care group.
Yes.
And you're just following those patients over time. How will you guys get data on the folks in the usual care group?
Well, I'll have gentlemen, so we're getting,
Just curious.
once the 63 are randomized at each center, the 63 are identified. It's a cluster randomized trial, so 15 clinics will get sort of the full court press, and 15 will get a lighter touch, but still better than usual care. So this is the usual care plus. So they get enhanced blood pressure monitoring and care management as well, right? At the front end,
I see. Is it
Yeah.
because
Yeah.
So what will happen, I mean, they may already, I'm not really sure if they're already going to be receiving care management, but what will happen is, along the lines of what Pete said, it's a cohort. So we're following 63 patients in the standard of care practices. Or like, let's say you have one practice called Chittima and another practice called Ogechi. That's my sister's name. So Chittima is the collaborative care and Ogechi is the standard care. And Chittima has 63 patients, Ogechi has 63. So what will happen is that the recruiters are going to ask patients at both Chittima and Ogechi sites, do you want to be part of this study? Once you get the 63 from Chittima's patients are going to be getting services from Danielle and Vanessa. Ogechi's patients who also agree to be part of the study aren't going to really get much of anything, but what they will get is every time they complete a survey, they get some kind of financial compensation as a part of being, as a token of appreciation for being part of the study. So we'll be comparing Chittima and Ogechi, and that's what my parents
I
don't
see.
do. They don't compare us. But
That's how you're ruling out the sort of like null hypothesis that.
Right,
Yeah.
exactly,
Okay.
Yeah.
yeah.
Yeah, I'm glad you brought up null hypothesis. You sound like an empty mouse. But the null hypothesis is we always set it up that in the end, these two will be the same, and we're trying to reject that.
Right,
So P
right.
of 0.05 means that they're 50% and 50%. We're saying that they're going to be the same at the end, and we want to reject that null hypothesis and find out that there is a difference, like 50, 80 would be great. And so the usual care does get enhanced blood pressure monitoring. Every center gets the OMRONs that you've all been trained on, and the blood pressure assessment approach. So we can compare the blood pressures between all the sites in the same way, because we have a standardized assessment of blood pressure. So that's the reason the OMRONs were put in, and the training that took place for the outcome assessment is going to be the same at all the different centers. So that's just a little bit of about the structure of trials.
I just have a question. Let's just say after the study is over, the outcomes are very successful. Would that approach from the study, would that be a point of utilizing more community health workers?
Yes.
Okay, yeah.
That would be evidence from a randomized trial. The highest form of scientific evidence is from our randomized trials that community health workers, care managers help in controlling. So as opposed to saying, I think it helps, or anecdotally saying, I think my patients like it, this would say it does help. You know, objective data of it being effective, so then it would translate into more resources for community health workers, and so that's the goal long term.
And that's why the stepped care is important too, because they could tease out what parts of the intervention are more likely to contribute to that outcome. So there's different levels here that we're trying to test as well. So.
And to both of the points that Pete and Joe just raised, that's also why this is structured as a pragmatic trial, because we want it to be sustained over time. So, you know, if for practices that are just hiring community health workers for the express purpose of being in the study, after the study they might be like, you know, I think we should keep these people around. Let's try to find funds to keep them as employees of Chittima, you know, like the Chittima Clinic.
And it's cost effective. If you keep them around, it actually helps keep people out of the hospital, and it helps.
Yeah.
This kind of evidence is important. So, you know, and the structure of our care management role as the PCPs, and I know you haven't met every. I know you saw Chadi. He spoke yesterday or 2 days ago. He's the cardiologist, and Deidre is the nephrologist. I'm the general internist and hypertension. Gail Domas is psychiatric. So sometimes psychiatric medications affect blood pressure. So you can see we're all about blood pressure in this study. This is a blood pressure study, but it's also all the other stuff. You know, diabetes and lipids and heart disease. So yeah, we focus on blood pressure as our outcome, but you know, we're happy to help with the other risk factors like smoking cessation. And we have a specialist here who works on smoking cessation approaches using Chantix or other approaches. So please feel free to access us. And if you talk to your providers, say, well, there's this resource, and you could get an opinion. And it's not a binding opinion. You know, we'll say, you know, our impression is this, our recommendation might be this, and the provider can take it or leave it. You know, it's not a binding approach, but it would have sort of a third party do an assessment. You know, we would look at this kind of data coming in today, having read this case last night, and so what are the things that I saw that might want to think about in sort of the next steps. And so we're hoping to meet weekly, and if you do, you know, we're hoping that a lot of people fall out early. You got them controlled, you're doing your case management and your community health worker approach, and you're getting people to take their medicines, buy the medicines, you're breaking down all the barriers, And so a lot of people are getting controlled and you never contact us. That's really what we want, right, gentlemen? We don't want to hear from anyone. But we're willing to hear, we're happy to hear from you. But what we hope in the end is that you're very effective and people become adherent and their blood pressure becomes controlled, so you don't need to access us, but we're willing to try to turn around recommendation within a week or so. If we, have opinions, so you get, six doctors in a room talking about a case, it's going to be chaos, but we will come up with a very succinct impression recommendation for cases that you bring to us. Having a relationship with the provider will be part of that, and it sounds like that's going to be different whether you're a community health worker or the care manager, and so how you facilitate that, you'll have to work on that. I guess
We can be very creative.
yeah.
I think for me, before this study, because I only know right now the providers in the infectious disease department, I don't really know many of the primary care providers at Total Health Care personally, so I'm thinking that for me, just to sort of introduce myself and people can put a name to a face, I'm gonna see if I can attend some of their multidisciplinary team meetings and just sort of introduce myself to the providers, so it just gives a softer approach to who I am and what I'll be doing for the patient.
I told you at the all staff meeting next Tuesday.
Okay. So I'm gonna do it at the all staff meeting next Tuesday.
They gonna speak about it, but I don't know. And let me just be quiet, because I do not like being up in front of people. But the not what we can go with.
Okay.
That's just me, I don't try to know.
Are you done? Do you
Sure.
have anything else that you wanted to add? Not me to, I don't know if you had any other thoughts that.
Well, one other thought I had is, if we, as a specialist care, sort of disagree with the primary care physician's approach to a patient, that's going to be a delicate thing. Like these people in the ivory tower of Johns Hopkins who are sitting around drinking coffee, weighing in on my case, say that he should not be on a certain medication. And that does create sort of this animosity, like you were pointing out to the provider who you gave suggestions to, I forget your name, but, and there's a sort of a pushback, like, that's my patient, and who are they, because they don't really know the nuances of taking care of this patient. So, so we'll be very sensitive to that we're not going to come in real strong and we'll say, you should think about this or think about that, and we're not going to say you should do this, or you should get an echocardiogram, or you should get a catheterization because he's having accelerated angina.